Hello friends, welcome to Dentistry Update, Journal Discussions. Today we are going to discuss about the most important topic in implant dentistry. Higher implant torques are used to give adequate primary stability. Does this insertion torques affect the bone and osseointegration? This article gives us a clear update about this. Residual cement after luting implant crowns is common and is recognized as a potential cause or exacerbating factor of peri-implant diseases, which might result in bone loss and implant failure. Some authors recommend avoiding cemented implant restorations because of risks posed by retained cements. These effects can be minimized by using supragingival and subgingival margins, but subgingival margins are often used. Authors have described various techniques to minimize excess cement by using copy abutments made using stock abutment analog, polyvinyl siloxane putty, PVS occlusal registration material, acrylic resins, composite resins, and hot thermoplastic glue. In the copy abutment technique, the crown is pre-cemented by filling it with cement and seating it onto a previously made copy abutment extraorally. After external excess cement removal, the crown is cemented intraorally by using the remaining cement, resulting in minimal excess. This article describes a simplified technique for cementing implant-supported restorations by using an ultra-thin cement shield membrane. The drapes around the abutment intraorally, which makes it a copy abutment. This eliminates the time and material-consuming steps. Custom abutment and cement retained crown, incorporating 50 micrometer die spacer. The abutment is fastened with appropriate torque. The screw access opening is filed 90% with sterilized polytetrafluoroethylene, Teflon pipe thread seal tape. Filling the access opening incompletely has been shown to retain cement internally and decrease external excess. The polytetrafluoroethylene tape is prepared by cutting the appropriate length of sterilized, 25 mm wide, 75 micrometer thickness. The length should extend at least 1 tooth beyond each side of the implant area. Stretch the tape up to a width of 75 mm. The properties of polytetrafluoroethylene allow it to be stretched without tearing. As confirmed by measuring with a thickness gauge, stretching the PTFE to 75 mm consistently decreases the thickness to about 25 mm. The facial and lingual portions should extend at least 10 mm past the gingival margins without any folds. Luting cement with extended working time, radiopacity, appropriate strength for retention, and retrievability. Adding approximately 10% petrolatum helps to balance retention and retrievability. Load cement sparingly in the intaglio of the crown near the margin area. Pre-cemented crown is completely seated onto shield-protected abutment with mild, vertical seating force. Statically crown will close due to hydrostatic pressure and binding but will not completely seat. Incomplete seating allows an adequate and appropriate volume of cement to remain in the intaglio of the crown. The excess cement will flow onto the external crown surface and membrane only, avoiding the protected gingival sulcus and fragile attachment apparatus. Immediately remove the crown and membrane from the abutment with all excess cement attached. Promptly detach the cement-covered membrane from the crown and remove all excess cement from the external crown surface by using a gauze pad. Also, remove cement adhering to the internal crown surface 0.5 to 1 mm above the margin. The only remaining cement will be a thin, optimal thickness layer inside the restoration. Immediately reseat the optimally cement-lined crown onto the dried abutment intraorally. Upon seating, apply moderate buccolingual and twisting force for 10 seconds. A well-seated, adequately retained crown, with minimal to no excess cement expressed at the margins, will result. As an adjunct to visual and tactile confirmation, expose a radiograph to further evaluate for residual cement. Under special circumstances where minimal excess is even more critical, such as after surgery, on immediate loading, or with unavoidably deep margins, modify the technique. In addition to removing external excess, remove internal cement 1.5 to 2 mm above the crown margins. Then, reseat the crown as previously described. This will help ensure minimal to no cement excess for an undisturbed implant and soft tissue healing. This article describes the use of an ultra-thin PTFE cement shield membrane to help minimize or eliminate excess cement when luting implant crowns. It is similar to the effective copy abutment technique and has been successfully used clinically for more than 4 years. The main advantage over the copy abutment technique is increased simplicity with savings of time and materials. Restorative dentists and surgeons can easily and routinely implement it to manage the risk of cement-induced PID effectively. Routine use can help minimize or eliminate the fear of residual cement as the reason for avoiding cement-retained implant restorations.